ACV stands for Above Cuff Vocalization, and it's a technique for us to deliver airflow through the larynx and upper airway whilst the tracheostomy cuff is inflated. When the cuff is inflated, the airflow is bypassing the larynx and the vocal cords and upper airway, so the patient loses their voice. And we know that loss of voice is psychologically really harmful for patients. They also feel like they lose their identity, they're powerless. It can be quite traumatizing. And giving patients back their voice is hugely powerful. We know that around 75% of people achieve some audible voice or audible whisper voice, enough for them to be intelligible and to communicate with their loved ones, with staff, to engage better in decisions about their care, and to really engage in rehabilitation with the whole multidisciplinary team. ACV can help patients who have delirium because we can tell how delirious a patient is by what they're saying. And we can also help the patient to become more engaged with staff because they can communicate their needs better. ACV is not just about getting voice. When the cuff is inflated, patients often get desensitized in the larynx and upper airway, and we need to give them a powerful afferent stimulus. So by giving them ACV airflow, we can literally switch the swallow back on and trigger the laryngeal adductor reflex that you need for both airway protection and cough. So we've seen the effect of this when we've done FEEs, because we can actually see the response at the laryngeal level and the vocal cords start to move with the airflow being delivered, and the secretions are expelled from the larynx. ACV is still really beneficial if a patient is drowsy or has low conscious level, because it can provide stimulation, secretion clearance, and support swallowing. Sometimes when you turn on ACV airflow, it can actually help to stimulate the patient and increase their conscious level. One of the great things about ACV is that we can start our intervention really early. And we know that the later that we do rehabilitation of the upper airway and the larynx and the swallow, the more dysphagia that we will see. And we want to prevent that becoming a chronic problem. And we want to prevent disuse muscle atrophy. As long as the cuff is inflated, the larynx has nothing to do. So we need to stimulate it.